So now we're doing yet another PowerPoint, myocardial infarction, 203. It's amazing how a 7-page PowerPoint can be summed up in just this much. So that's why I think it's beneficial to just go through it. Sustained myocardial infarction, aka a heart attack, is basically a sustained ischemia. We all learned recently that ischemias are related to angina and there's just damage. But when it's actually sustained ischemia, there's cell death involved. So in relation to the heart, sustained ischemia is usually due to three things, and that's spasms, blockage of some sort, specifically in the coronary arteries, and a condition where there's a decrease in O2. And if you put it all together, you know, when there's a decrease in O2, you know that you're going to be spasming. You know, you think of things like Raynaud's. When there's no O2 in those small arteries, arterioles, you know, you're going to get into spasms. Anyway, it causes irreversible cell death, right? Then we talk about myocardial necrosis, because cell death is dead tissue is necrotic tissue, myocardial necrosis. It's a part of the heart, depending where it's necrotic, that will never pump again. It will never do what it's intended to do. And as a result, you're going to have a decrease in ejection fraction, and you're going to also have a decrease in cardiac output. So, hence, almost heart failure to some extent. The most common MI is in the LAD, otherwise known as the widowmaker. It is 40 to 50% probable in all heart attacks. Then you have the right coronary artery blocking at 30 to 40%, and the the circumflex would be at the 15 to 20% range. I'm trying to do this without looking because I need to learn it too. Your objective subjective presentation. For those of you who can't digest what that means, it's signs and symptoms. Yeah, I'm not really funny, I'm sorry. So we're looking at indigestion. You know, often the time people say, oh, they didn't go to the hospital because they just thought they were having indigestion. So you see that nausea and vomiting. Then you have chest pain. Then you have low-grade fevers, oliguria, producing 20 milliliters every hour of urine or less. Then you have a patient who's very anxious. Obviously, you know, I'd be super anxious. I wouldn't even know how I'd deal with that. You'll have an increase in ESR and an increase in white blood cells. Obviously, there's some type of inflammation and some type of infection of some sort. Something wrong going on. Your body's reacting by elevating the white blood cells. You'll have rales and crackles secondary to pulmonary edema. In those cases, some people will even have to use a V-mask or a worst case scenario, they'll need to be intubated. And shock symptoms, you'll see shock symptoms. And that's basically it. That's what your patient will look like when he's coming in. Those will be his complaints, what you'll observe upon assessment. Treatments. Treatments, vital signs, very important. You want to assess vital signs continuously. You want to know what's going on with that patient. You want to have a baseline before they came in, and if it's getting progressively worse, improved with medication therapy and whatnot. Pacemakers. There's two types of pacemakers. We learned about the atrial pacemakers and the AV sequential pacemakers. Just remember, atrial pacemakers are the ones directing all the activity from the SA node, giving it that one beat, you know, the one that's missing. The atrial sequential, more commonly seen in, I believe it's third degree heart block, because in third degree, the atrium and the ventricles, while they're both pumping, they're not doing it sequentially and nothing's really effectively going on. So the AV sequential pacemaker will direct the two beats to make it more efficient, or obviously death would occur, if I'm not mistaken. Margie, am I right?
Yes.
Make sense?
Mm-hmm.
Alrighty, I'm going off on tangents. Bedside commode, you definitely want a bedside commode. You don't want the patient walking 15 blocks to the fucking bathroom or whatnot. You want to provide stool softeners. A goal is definitely we don't want that patient straining and causing any more workload for the heart, or vasovagal too. Oxygen therapy, I mean, that's self-explanatory. Thrombolytic agents. Thrombolytic agents are definitely going to be used because what we're trying to do is to dissolve existing clots. Remember that thrombolytic agents do not get rid of Wait, does it dissolve? Yeah, it does dissolve existing clots. It just doesn't break them down. I don't know. Anyway, just remember it dissolves existing clots. Sorry, I had to bring it apart. You're going to get 2 boluses, 30 minutes apart. If it's therapeutic, you'll see a decrease in the patient's pain level, and you'll also see changes in the EKG. So that's cool. If it's not therapeutic, or if the patient can't have a thrombolytic agent for some reason, if it's contraindicated, that patient needs to go to the cath lab stat and get an IABP. An IABP is an intra-aortic balloon pump, and what that's going to do is help assess with levels of fluid, more accurate readings and things like that. And then they'll have stat surgery, or at least within 8 hours, something to that event. Foley caths. You need Foley caths because this patient's going to be on a lot of diuretics. We're trying to get that fluid circulating, and we're giving them all these meds to make the heart pump, and as such, we'll need it. I believe he said something about mannitol being used as the preferred diuretic in this case, but you'll also see people on Lasix and Bumex and all that other stuff. Unstable patients. Your unstable patients, when we're talking about them, we're talking about people who are hemodynamically not balanced. You know what I mean? So using intra-aortic blood pressures and PAPs, otherwise known as your Swan-Ganz, those are really good assessment tools for fluid balance, for monitoring fluids, for pressure as well. But PAP is basically Swan-Ganz. Chest pain, you're going to be using IV nitro drip, closely monitored obviously. You're going to use morphine sulfate. Morphine sulfate, its number one direct effect is pain relief, and that's important in this patient. But the secondary relief, in this patient particularly, the secondary use is that it vasodilates too. So that's going to help in the flow of things as well. And beta blockers, at least 3 doses I believe from what I read in this PowerPoint. Complete bed rest times 24 hours. So more than likely this patient might even have compression devices and stuff because we don't want to have any DVT complications as a result of him being just stasis kind of. Heparin therapy, it's going to help with pulmonary embolisms, CVAs, and any additional coronary thrombosis. IV antiplatelet therapy, typically used for unstable angina or continued chest pain. The medications used for this is RioPro, Aggrastat, and Interol. Then you have cardiogenic shock. For those patients, you're going to use the intra-aortic balloon pump we spoke about and the PAPs, otherwise known as the Swan's cath, for great assessment tools for their fluids. Complications. Very simple. These complications could lead to CHF, could lead to pericarditis. The way to rule out pericarditis in this scenario is that you would perform an echo, and echo will show you. Now, I don't know if we mentioned it before in our pericarditis video, but a very star, I believe, is that the characteristic symptom of pericarditis is actually dyspnea. Make a note of it. Then you have extension of MIs. You want to repeat those thrombolytic agents, those antiplatelet agents, and maybe possibly another coronary angioplasty with stents or whatever. And then cardiac dysrhythmias. We're going to talk about cardiac dysrhythmias later. But obviously there's lots of medications for cardiac dysrhythmias. And there's a ton of them. And that concludes MI. The 7-page PowerPoint summed up in just a few words. You can thank me later.